Greetings everyone, I am Dr. Abhishek Samdesi and we will continue with Abg Simplified Part 5. In this video, we shall discuss regarding the etiology of metabolic alkalosis. So what is metabolic alkalosis? Metabolic alkalosis is when there is rise in plasma bicarbonate more than 26 milliequivalents per liter associated with increase in pH. This is metabolic alkalosis. Whenever we have metabolic alkalosis, we have the accompanied hypochloremia and hypokalemia. The mechanism I have explained in my first video in Physiology of Acid-Base Balance. Looking at the types of metabolic alkalosis, we have two types. One is chloride responsive, the other is chloride resistant. Now, when do we call it chloride responsive is when urine chlorine is less than 25 milliequivalents per liter. We call it chlorine resistant or chloride resistant metabolic alkalosis when urine chloride is more than 25 milliequivalents per liter. It also means that whenever you're suspecting a case of metabolic alkalosis, it is advised that you send urine for chlorine to know whether it is chloride resistant or chloride responsive. So what are the causes of chloride responsive metabolic alkalosis? These are the following causes. The first one is the loss of gastric hydrogen ions. The second one being chloride losing diarrhea. The third cause is cystic fibrosis and it is also seen in post hypercapnia. Now what are the etiology or the cause for chloride resistant metabolic alkalosis? These are the following. First is mineralocorticoid excess. Second is by use of active loop or thiazide diuretics. And the third thing is exogenous alkali load. And fourth is severe hypokalemia. Now let us look at it one by one. The causes of chloride responsive metabolic alkalosis, as mentioned before, are because of loss of gastric hydrogen ions, or if there is chloride losing diarrhea, or cystic fibrosis, or post hypercapnia. So when we talk about loss of gastric hydrogen ions, it happens in case of vomiting or gastric suction. Talking about the cause of chloride losing diarrhea, it happens in laxative abuse as well as villus adenoma. These are the causes of chloride responsive metabolic alkalosis. Next, talking about non-chloride responsive metabolic alkalosis. The causes are mineralocorticoid excess, active loop or thiazide diuretic use, Bartter or Gitelman syndrome, exogenous alkali load, and severe hypokalemia. Now, the causes of mineralocorticoid excess is Cushing syndrome or Liddle syndrome. Talking about exogenous alkali load, the causes are exogenous bicarbonate infusion, milk alkali syndrome, as well as administration of citrate containing blood products. So how does this hypokalemia cause chloride non-responsive metabolic alkalosis is because of hypokalemia, the renal starts excreting excessive hydrogen ions. So this results in chloride non-responsive metabolic alkalosis. These are the etiology of metabolic alkalosis. In the next video, we will be discussing regarding the clinical manifestation and interpretation of metabolic alkalosis. Thank you.